We will
Thanks.
move on now to the rapid podium presentations. And we have 3 posters, and we should have time for some Q&A at the end of all 3 of the posters. So we'll wait till all 3 of them have been presented. And I think Josh is taking care of this. So I don't think I'm supposed to do anything, am I? Christian and Josh, I think you're, yes. Okay, great. Thank
Hello,
you.
and thank you for visiting my poster, which details my most recent study entitled An Interrupted Time Series Analysis of the Influence of Canada's First Concussion Public Policy on Rates of Concussion-Related Visits to Emergency Departments and Primary Care Providers' Offices by Youth in Ontario, Canada. There were 2 objectives of this study. The first was to examine rates of concussion-related visits to emergency departments and primary care providers' offices by Ontarians ages 4 to 18 years, to assess whether there has been a change in rates associated with the introduction of Canada's first concussion public policy, Policy Program Memorandum 158, commonly known as PPM 158. The second was to determine whether there is a differential influence of PPM 158 by various socio-demographic variables, namely sex, age, neighborhood income level, and rural versus urban residents. We hypothesized that there would be a change in both level and trend following the introduction of PPM 158, and that there would be a greater differential effect in females, the oldest age group, and youth in rural residences.
I
The data source used in this study was from the ICES. We accessed linked administrative health data for the years 2004 to 2019. Our study sample was defined by diagnostic codes from the International Statistical Classification of Diseases and Related Health Problems, or ICD. Specifically, ICD-10S06.0 for concussion for emergency department visits, and ICD-9-850 for concussion for physician office visits. For a statistical analysis, segmented regression in an interrupted time series design was used to assess level and trend changes after 2 policy events to describe the impact of the policy events on the outcome measure, which was the rate of concussion-related visits per 100,000 per year. The 2 policy events included in the analysis were 1. The world's first concussion law, known as the C.E.T.S law in 2009, and 2. Canada's first concussion public policy, PPM 158, effective in 2015. There were 3 time periods selected based on the 2 policy events and visual inspection of the data. Period 1 from 2004 to 2008, and this was before any policy. Period 2 from 2009 to 2014, and this was between the C.E.T.S law and the year before PPM 158. And period 3 from 2015 to 2019, which was from PPM 158 to the end of our study period. We also conducted some sensitivity analyses. The results showed that there were indeed significant level and trend changes associated with both policy events. We focused here on PPM 158. We found that there was a significant positive level change, which signifies an immediate change. There was also a significant negative trend change, indicating that the rate of change of the rate of concussion-related visits decreased over time following PPM 158. There was a significant differential influence of PPM 158, such that there were more visits immediately after introduction in the oldest age group and higher income group, with greater decreases in trend as well. There were no differences between the sexes or rural versus urban residents. There were significantly more visits to primary care provider offices since 2010. Overall, PPM 158 is associated with both level and trend changes. Heightened awareness may have contributed to the immediate level change, and prevention strategies or changes to participation in sport may have contributed to the decreased trend. This work helps bridge a gap in knowledge about the impact of concussion public policy in Canada. Thank you.
Thank you, Swapna. And I should have introduced you before your poster. Swapna is an MD PhD candidate at the University of Toronto. She's supervised by Dr. Charles Tater. And as you can tell, her research focuses on concussion public policy. And now we will go on to the next poster. And this is a poster by Dr. Jennifer Dawson on improving patient outcomes, living guideline for pediatric concussion care. And Dr. Dawson is a research associate at C.E.T.S Research Institute and in Ottawa, and is the project coordinator and guideline developer for the PEDS Concussion Project, the living guideline for pediatric concussion care.
Hi, my name is Jennifer Dawson, and I am a research associate at the C.E.T.S Research Institute in Ottawa. I'm also the guideline developer for the Living Guideline for Pediatric Concussion Care. The Living Guideline is a large collaboratory project that includes over 50 concussion experts, clinicians, and knowledge translation experts from across North America. The project leads are Dr. Nick Reed from the University of Toronto and Dr. Roger Zemek from C.E.T.S. This project first started in 2014 when Roger Zemek released the first edition of the guideline. We updated the guideline based on new research in 2019 and also pivoted the project to a living guideline model. That means that we now do not need to wait 4 or 5 years between editions to share latest research, and it ensures that our recommendations are always up to date and reflective of the latest research findings. I'll briefly walk you through how this works. We start off with a bi-monthly literature search and identify critical papers that pertain to the pediatric guideline. We share these papers with a panel of 40 experts from across North America who work together through a transparent consensus process to determine whether this research needs to be incorporated into the guideline and modify recommendations. All of this is shared on our website, pedsconcussion.com. I encourage you to go to the website and check it out. You'll find a web version of the guideline recommendations. There is an option to download the entire guideline in PDF form. There are also numerous clinical algorithms and community handouts that can be helpful to share with stakeholders. The guideline itself is broken down into 15 domains. The first 7 domains pertain to recognition, initial medical management, and prolonged concussion. We also have a new domain that shares information on telemedicine and virtual care. There's an algorithm that identifies which patients may be eligible for virtual care, and also there's a tool to help clinicians learn how to provide care virtually. We then have 6 domains that pertain directly to managing both acute and prolonged symptoms of concussion. And finally, we share 2 domains on upcoming research in neuroimaging and serological biomarkers. Thanks for coming to my poster, and please do reach out if you have any comments or ideas. Our team would greatly appreciate hearing from you.
Thank you very much, Jennifer. It's another great presentation. And our third poster is moving in a really different direction by Dr. Benjamin Dunkley on intrinsic and motor-related neural bursting intrinsic and motor-related neural bursting dynamics are disrupted by mild traumatic brain injury. And Dr. Dunkley is a scientist in the neurosciences and mental health program and diagnostic imaging at the C.E.T.S Hospital and assistant professor in medical imaging at U of T. And his poster will come up in a second, and we'll have time. We'll have a few minutes for questions afterwards. We'll just shorten our break, which is supposed to be 30 minutes, by a few minutes to enable us to have a few questions for our poster presenters.
Hello, everyone. It's great to be speaking with you today. My name is Ben Dunkley. I'm a scientist and assistant professor at C.E.T.S and U of T. Today, I'm going to be talking about a study that came out late last year in Neuroimage Clinical, where we used MEG to study neural dynamics in NTBI. So we know that NTBI impacts the repertoire of neurophysiological activity. And a phenomenon that's received a lot of attention in recent years is that of neural bursting. So these are transient-like events in the brain that are thought to reflect thalamocortical and corticocortical circuits. So we applied this approach to study them in MTBI in a group of young adults in the subacute phase using magnetoencephalography, which is an electrophysiological technique that can pick up these bursting phenomena. Here we can see in the right figure the typical topography of bursting states in the brain and controls, and in the left we can see our MTBI group. And there were deficits in the MTBI group that appeared to be brain-wide. This was a brain-wide phenomenon, showed to be significantly reduced in MTBI, but predominantly in bilateral frontal vortices, these changes were found. Bursting also allows us to calculate a measure of functional connectivity and communication within the brain. We can measure the coincidence of these bursts. So if they appear in time coincidentally, that's a way that different areas of the brain communicate with one another. Here we can see in the top row our MTBI functional connectome, and in the bottom the control network. And when we look at the differences between these two brains, we find there were significant reductions in functional communication across many different areas, including bilateral, somatosensory, motor, and parietal cortices. Now, these neural bursting phenomena are also key in motor control, and we applied a button press paradigm. And what happens when the motor cortex initiates a movement is that these burst type phenomena are actually suppressed, and you can see that about here on this time series. And then there's a subsequent bursting phenomenon, like a post-movement beta burst rebound. And what we found is that this was greatly deficit in our MTBI group. This recalibration of the motor system mediated by this bursting phenomenon in the post-movement stage was greatly suppressed. And you can see this down here in the figure on the right. So we found that MTBI results in multi-scale neurophysiological disruption across many areas of the brain, that this manifests as deficits in this bursting phenomenon, that these bursts are driven by interactions between thalamocortical and corticocortical inputs, and this suggests that there is large-scale disruption to these circuits after MTBI. In terms of our future directions, we hope to continue to study these phenomena using a new generation of OPM sensors that afford us much greater sensitivity. Thank you for your time.